Okay. Hello and welcome to Hernia Patient Support Group and to our live chat. I'm Jackie, one of the group admins, and I'm delighted to be able to introduce you tonight to Dr. David Yates from York NHS Hospital. Now, Dr. Yates is an anaesthetist and consultant in intensive care medicine. I think I've got that right. And he's going to talk to us tonight about the different types of anaesthesia and explain to us what the procedure is when we go for anaesthesia. So, welcome, Dr. Yates, and thank you very much for joining us tonight.
Thank you very
This
much.
session is being recorded and it will be available to view later on tonight in YouTube. So, I think most people, when they're facing an operation, worry about anaesthesia, don't they? It's something that it's for me. It was the thought of not being in control and somebody else having to take control of my breathing and all my body. And I think it can be a source of real anxiety for us. So I think you're going to explain to us, aren't you, about what is anaesthesia?
Absolutely. Yeah, I thought I'm going to do a very quick, very short history of sort of where anaesthesia's come from, and then a little bit about the different types of anaesthesia and what to expect on the day of surgery, sort of taking the patient through from being listed for an operation to actually go to the surgeon saying you need a hernia operation, right through to the recovery phase afterwards and all the different steps you'll go through. And then I thought I'd talk a little bit about the risks of anaesthesia. And then I know we've already had some questions, haven't we, Jackie, that I've got a little list to remind me for things that people wanted to ask about. And hopefully I'll answer some of the other questions as well. But we'll see.
If anybody does have questions, please feel free to use the chat box and we can discuss those.
Lovely. So I've got a little presentation. Is it okay if I share that
please
now?
do. Please.
See if I can make this work again. How's that? Is that working?
That's great. Yes. Thank you.
Lovely. Good. Right. So hello. Good evening. My name's David Yates, and I'm an anaesthetist and intensive care consultant. So I do a bit of both, and I work at York and Scarborough teaching hospitals in the north of England. And what I thought I'd do this evening is just take a little bit of time to talk about what is anaesthesia and give you a little bit of a history of general anaesthesia and where it's come from, and then tell you who we are, what an anaesthetist actually is, and then talk about the different types of anaesthesia that you may have heard about, and then go on to what to expect on the day for your hernia surgery, and talking a little bit about the complications and risks at the end of it. So first of all, what is anaesthesia? Well, I've put this up. It's an anaesthesia literally means without sensation. Anaesthesia, and a modern anaesthetic is three parts to it. There's sedation or sleepiness, being asleep, loss of consciousness. There's pain relief, so we have no pain when patients wake up from the operation. And then there's muscle relaxation, which sounds a bit odd, but that's all to do with a surgeon actually being able to do what he needs to do. And if you can imagine someone having to do an operation on the wall of the tummy, on the abdominal wall, well, if your stomach muscles are contracting all the time, it's very difficult to do an operation. So often we have to give drugs to actually relax those muscles. So an anaesthetic is derived of either all three of those things or just maybe two of them. So you don't have to be sedated. So we can have different types of anaesthesia. A general anaesthetic mainly involves all three of those things. So being unconscious, being given some medicines for pain relief, and frequently being given some drugs that result in the muscles not working properly and muscle relaxation. But a regional anaesthetic, which we'll talk about later, might be something like a spinal anaesthetic, which is what ladies have when they're having cesarean sections so that they can stay awake for the birth of the baby. And we'll talk about what we actually do. But for something like that, we wouldn't sedate the lady. So you'd have pain relief, you can't feel any pain, and the muscles aren't working very well, but you're not sedated. So you don't have to have all three of these things. And then a local anaesthetic involves the surgeon just injecting a bit of local anaesthetic into that area, which switches the nerves off where he's injected. and there's no sedation involved there or muscle relaxation. It's just pain relief. So anesthesia is made up of one, two, or three of those things. And a very brief history. I'm only going to take 5 minutes to do this because it's not what you really wanted, but I quite like it. The history of where it all comes from. So it all comes from near me, actually, near Leeds. Joseph Priestley. He was a chap in the mid 18th century, around 1740, that isolated nitrous oxide. And I don't know whether you've ever seen it, but these are those little silver bottles that you sometimes see at the side of the road that the kids have been abusing, basically, and breathing in nitrous oxide, and it makes you feel high. And he first of all discovered this, and thought this would actually be quite useful in good time for all sorts of medicinal things to allow us to do procedures. And then following on from that, not much happened for about 50 years. People couldn't really work out how to use it until we then developed drugs like ether and chloroform, sort of in the middle of the 18th century. And ether was first given over in America, in Boston, for someone having an abscess lanced on their neck. I don't know if you can see that there, but of course, everyone sat around watching it. And people were absolutely gobsmacked because this was the first time that anyone had ever seen a patient be made to go to sleep, properly to sleep, to be anaesthetized, and then woken up again afterwards. So previously, we'd given a bottle of whiskey and a piece of wood to bite on, and told they're practically unconscious because of all the whiskey, but you couldn't wake them up again straight away afterwards. That took a long time if you managed to. So this was really the first time that anyone had actually seen this done. And then in the what's happened there? There we go. In the mid 19th century, this chap, James Young Simpson in Edinburgh, administered chloroform for the first time. And that led on to a whole host of people getting involved. And one of them was a chap that was born in my town in York in 1813. And he actually gave chloroform to Queen Victoria when she was having her 8th child, Leopold, in 1853. And said Dr. Snow gave that blessed chloroform, and the effect was soothing, quieting, and delightful beyond measure, is what she wrote. And he was also, interestingly, the first epidemiologist, because he traced the cholera epidemic in London back to the water pump on Broad Street, and then took away the pump handle and cured the cholera epidemic. So anyway, so that was really the first anaesthetist. Then over the next coming years, we started developing airway devices because we were making people unconscious. And then realized, well, if they're unconscious, the tongue flops back and they lose the airway. So we need devices to keep that open. And then we worked out how we could actually give a drug to relax those muscles that we were talking about. And that was curare. And that came from South American indigenous population who were making this chemical from tree bark, and then blowing it through poison darts to kill animals to eat. So it's all sort of stemmed from nature, these things. Then in the early 50s, there was a polio epidemic in Copenhagen, and we worked out how to actually ventilate patients, if you send somebody off to sleep, how you could then make the lungs go up and down and make gas go in and out of the lungs so that you can actually keep them alive. And really, that polio epidemic in Copenhagen was the start of modern intensive care. And then really, it wasn't until the 70s and even 80s that we start developing the drugs that we see in theatres today, in operating theatres today. So those are inhalational anesthesia agents, and these are gases that we breathe in and they keep us asleep. And then the big one was propofol, which is, if those of you have had an anaesthetic, is the milky-like substance that you see in the syringe, and that's what we actually use to get most patients off to sleep. So it's come a long way in a couple of 100 years. We've gone from the old bottle of whiskey, hold them down and chop the leg off if necessary type thing, to a fairly modern, controlled, planned way of delivering safe operations. Back then, nobody had an operation unless they were going to die without the operation. Whereas these days, we can choose to replace hips, we can do cataract operations, we can fix hernias, and we can do it in a way that allows us to keep a very close eye on the patient's physiology, so we can keep an eye on the heart rate, the blood pressure, the oxygen levels, the amount of carbon dioxide that's coming out of patients' lungs, whether the brain, what the brain activity is, so we can see the depth of anesthesia and how deeply anaesthetized the patients are. So we've got an awful lot of kit and monitoring that's really come about in the last probably 30 to 40 years. So the people that taught me to be an anaesthetist were the ones that actually took our specialty from a pretty archaic, flying by the seats of your pants sort of activity to a really very, very safe and risk averse and risk aware profession that we've got today. So, what is an anaesthetist? Well, to become an anaesthetist, you've got to do 5 years at medical school. You then have to do 2 years immediately after medical school as a foundation year doctor. You then have to do another 2 to 3 years as a core trainee in anaesthesia. And then you have to do another 2 years as a specialty trainee. After that, we've got the Fellowship of the Royal College of Anaesthetists exam that you need to take to be allowed to then go into your higher specialty training, which lasts for about 3 or 4 years. And once you've done all that, you are given your badge, your ticket to say you can become a consultant anaesthetist. So it takes quite a long time and a lot of anaesthetics. The training has got a lot better over the years, and it's gone from, in my day, which was a bit of an apprenticeship, I suppose. You just did lots and lots and lots of anaesthetics and got good at it by volume. Whereas now we very much train the next generation of anaesthetists in how to do it, and we, the consultants, deliver it, but training junior doctors and residents along the way. So today in the UK, there's about 7,500 consultant anaesthetists. And that's of the 58,000 consultants, that's about 12% of the entire workforce. So there's an awful lot of them. And that's about 6,000 resident doctors, which we used to call junior doctors. So those are the ones in training. And even with those, what's happened there? Sorry. So even with that many consultants, if you can see that graph, we have about 14 anaesthetists per 100,000 people in the UK. And when you compare that to the rest of Europe, we've got a lot less. And this is a problem that's been brewing up for years and is still a big problem, even more so in the post-COVID time, where we just simply haven't got enough anaesthetists to get these waiting lists down that we're struggling with. So what do we actually do? Well, our job is to make sure that a patient is asleep, anaesthetised when they're meant to be anaesthetised, that they're kept safe, that we've gone through things with the patient beforehand to talk about whether an operation is actually the right thing to do for this patient. There's a lot of operations that we can do, doesn't mean it's the right thing to do. We do what we can to minimise the risks to that patient, and during an anaesthetic, we'll pay very careful attention to maintaining your normal physiology. So your blood pressure is normally at a certain level, your heart rate is normally at a certain level. My job as an anaesthetist is to take you from being awake with a blood pressure and a heart rate and an oxygen level where it normally is, to asleep with a blood pressure and oxygen level and heart rate in that same range of numbers. Because that way you're not coming to any harm, problems like heart issues and breathing issues afterwards and things like that. And by doing that, we think we can reduce the stress that the body goes through from having surgery. So at the end of the day, even though surgeons are doing good by doing an operation, it is still a trauma to the body, isn't it? If you hurt yourself or you break a bone accidentally, you've undergone trauma. Well, if a surgeon has to break your hip bone to actually give you a new hip, and they do, then that is traumatic. So what we aim to do is to attenuate that, to make that as less of an impact for the patient as we can. And we make sure that we deal with pain and nausea and vomiting, and that we act in the patient's best interests. And also the smooth running of an operating list. I'm sure my surgical colleagues will be the first to say that an anaesthetist that's in charge of the list and gets things moving and gets the patients into theatre when they need to is really good and makes things much more efficient. So there's so many anaesthetists because we get around all over the place. We're in the operating theatres, we run intensive care units, we run the pre-assessment clinics, we get involved in radiology, we have to do epidurals for ladies in labour and then spinal anaesthetics for those having caesarean sections. We run the paediatric intensive care units, we work in emergency departments, we provide outreach. That's a bit like critical care, so intensive care, going out to the wards to see sick patients on the wards. And we run chronic pain and acute pain and cardiac arrest team, etc. So we get around all over the place. And that's why we have so many of us. So moving on to the bit that you actually wanted to hear, having an operation for your hernia. What I thought I'd do is just take you through the process. And I'm sorry if this seems a bit simplistic, but I thought actually a lot of people, when they're listed for an operation, and that's the process, the surgeon puts you on his list for surgery, they don't actually know what happens from then onwards. Where do we actually, when will you call me? What will happen? Do I need to do anything? And the process that's going to happen is you will be asked at some stage to come for pre-assessment clinic. And once the team are happy that you are okay to have an operation, and that's really what the pre-assessment clinic is for, is to make sure that things are okay to proceed and that the anaesthetic won't be too risky or the surgery won't be too risky and that there's nothing else that stops us going ahead. You'll be given a date for surgery. And when you come in, you'll be admitted to the hospital. And that will either be a day case. So most people having maybe an inguinal hernia or a femoral hernia or an umbilical or epigastric hernia, that may well be done as a day case. So in and out in a day. And we do, in the NHS, we do about 85% of all our operating is done as day case operating. So there's the bigger inpatient procedures, which are things like having lung cancer surgery, for instance, or a hip replacement, or a bigger hernia repair. So a big incisional hernia repair or an abdominal wall reconstruction or something like that. That's not going to be done as a day case. The patients need time to recover after the surgery. There's more invasive things going on with the procedure. There might be drains left in, or it might need a drip after the operation, or intravenous antibiotics. So patients need to stay in. And then we talk about the recovery and the discharge process after that. So pre-assessment clinic is normally these days, well, since COVID, we've gone from having a face-to-face where patients would come in and sit with a nurse and talk about their previous health, previous operations, their general health, all that kind of thing. An awful lot of it is now done via telephone. And we've realized from COVID, because we had to, that you can actually do it that way. If somebody is young and fit and well, a telephone pre-assessment is absolutely fine. We can get all the information we need from that. Often patients will be sent a form to fill in on a tablet or the computer that gives us the information we need. And then a nurse will look at that and triage it and say, yep, this patient can just come in, they can have a date for surgery and come in. Or they may say, oh no, this patient's got diabetes and heart problems and things like that. I think they need to come in and I need to actually meet the patient. And then I may actually get one of my anaesthetic colleagues to come down and meet the patient as well to talk through the process of anaesthesia. So we're going to want to know about medicines and allergies, and it's a good idea to take your medicines, or at least a list with your medicines written out on, to a pre-assessment clinic appointment. And it means we can get all the baseline investigations we need. So the blood pressure, the height and the weight, and getting a tracing of the heart and various blood tests and things like that. At the pre-assessment clinic, the nurse will always take you through what to do with medicines in the days before surgery. And those are often very specific to both the type of hernia surgery that you're having, but also the reason why you're on those tablets. So, and blood thinners, blood thinning tablets are the big ones. So people can be on blood thinners for all sorts of reasons. And depending on why you were put on them, we would either stop them for a decent period of time before surgery so that there's no bleeding, not too much bleeding when the surgeon does the operation, or we might do different things like changing it for a different tablet and all that kind of stuff. So it's different hospitals have different protocols, so you may hear different things along that line, but each hospital will have its own dedicated process of what to do for what type of surgery for that type of patient. They'll take you through what to expect on the day itself and when to come in and where to come in. And most people will be admitted to a elective surgery waiting area where patients would come in and all wait for their operation. If you're lucky enough to have your operation in a private hospital, and we do an awful lot of NHS operations in private hospitals these days, you might just come into your own private room. They'll give you information on eating and drinking before your operation, and as it stands, we like people to have not eaten anything for 6 hours before surgery. And it was a slightly old-fashioned way of looking at it now, of not having had any fluids at all up to 2 hours before your surgery. Now we've got this thing called sip till send. So we ask patients to sip just small amounts of water, so 70 mils an hour, up until we send for them for surgery. And we actually think that that's probably much better because it keeps patients hydrated and it doesn't cause any problems. The reason for not eating is that when we anaesthetize you, we don't want things that are in your stomach to come back up into your mouth and cause problems with the airway. So in pre-assessment clinic, the nurse will often take you through the procedure itself, the expected recovery, and they'll have been informed by each individual surgeon. This is what I want you to tell my patients. We expect after an inguinal hernia repair, it will take several weeks to get back to how you're feeling, to how getting back to work, and they'll give advice about heavy lifting and all that kind of stuff. And we'll often talk about research as well. And there's a lot of research projects going on in the NHS hospitals, and if there's opportunities, then you will be offered the opportunity to take part in research projects. It is actually part of the NHS constitution that every patient should be offered that opportunity whenever they go into hospital. So we want to try and beef that up because that's how we improve healthcare. And then they'll tell you about preparing for your operation. And I've broken this down into two main blocks. I was wondering whether we might do another session like this on sort of preparing for surgery, about lifestyle type things. But that is things like stopping surgery and eating healthily and cutting down on alcohol and all these things that are very, very easy for doctors to say, but maybe not quite so easy to actually do a lot of the time. But again, we're developing strategies to help people who are coming up for surgery to try and address these things to get themselves fitter for surgery. And we have there's a link there to the Royal College of Anaesthetists, RCOA. There's a lot of documents on there that patients can look at about getting fitter for surgery. We have a whole program called Fitter, Better, Sooner. So getting fit for your surgery and getting better sooner after your operation. And also preparing for your surgery, it's things like the practicalities of it. Does the date suit you? Can you do that day, or are you on holiday? It's perfectly okay to say, I'm on holiday. Sorry, can you give me a date in 2 weeks after that? And the booking clerks, the waiting list clerks will often do what they can to get you fitted in. Definitely don't have to go back to the bottom of this very long list. Have you got someone to pick you up after surgery, or if it's a day case, or to look after you? Have you sorted out what who's going to walk the dog? You worked out what's going to happen with work. How much time do you need off? What are you going to do if you've got to stay an extra day in hospital, or you have to stay over? It was planned to be a day case operation, but you have to stay in for whatever reason. So it's all those practicalities that we need to work through. Have you got painkillers at home? And things like, have you got medicines in the original boxes that you can bring into hospital with you so that we know what you're taking and what's happening? There's all sorts of things that we need to do in preparing for surgery. And then on the day, I think the first thing to say, it's okay to be nervous. So we chatted about anxiety just before we started this. This is one of those things that is, once, twice, 3 times in a lifetime experience for a patient. And it's a 6 times a day experience for me on the other end of it. So on one end of the needle, you've got someone that does this every single day of his working life. And at the other end of the needle, you've got someone that may have never been into hospital before. And that is pretty terrifying. Most people, or the worst groups, I think, are young blokes. So young blokes are really quite scared of it all, and they all faint as soon as you get the needle out. And then ladies who have got their acts together if you don't mind me saying so. So ladies who are in control, who have a busy life, they're running a business, they're running a family, they've got a job. That sort of concept of coming into hospital and giving up control, I think it's that actually affects people really badly. And in terms of strategies to deal with that, I find the best is to say that's okay. That it's just normal. You're not unusual. It's completely normal that you're feeling like that. And the best way, as far as I'm concerned, the best way to get through that is to acknowledge it, to say it's normal, and to say, should we just get on with this as soon as we can and get you done and get you sorted and get you back to running your life, back to what you normally do. So on the morning of surgery, the patients will meet the surgeon and the anaesthetist. Often a consent form will have been done in clinic with the surgeon, but they might do one on the morning or get you to look at it again and go through the risks and benefits of doing an operation. They will mark you. So everyone always needs a pen mark on them so that we make sure we fix the right-sided inguinal hernia and we don't go hunting around looking for a left-sided inguinal hernia. So they will draw on you literally with a big black marker pen. Comes off after a little while. And then in that pre-admission area where we normally come in, so waiting for your operation, patients will be changed into a gown. They'll have the name tags put on the wrist, sometimes on the ankle as well. Often red bands if you've got an allergy, so that anyone giving you any medicines thinks, "Oh, red band, better watch out for that. What are they allergic to?" And then they can make sure they're not giving that drug. You get a bag for your belongings, so dressing gown and slippers and things like that. We want to take as much jewelry off as we can, but we don't worry about wedding rings and things like that because they can just be taped up. And the reason for doing that is that when you're asleep and the surgeon's using diathermy, so electric cautery device to stop the bleeding, we don't want any part of you with any metal attached to it touching part of the metal table because you'll be grounded and they'll short circuit that device and end up with a burn or something like that. So it's all those technical things, those very, very safe devices, as long as everybody is on the ball of as what's going on. So you'll always be asked, have you got any jewelry on, any piercings and things like that? We're always surprised by the odd piercing every now and again. A lot of people get these elasticated stockings. So you hear them called TED stockings or these compression stockings to stop you getting blood clots in your legs. Sometimes they do, sometimes they don't. It just depends on the policy of the hospital. Ladies will be, those that can have babies will be offered a pregnancy test if it's appropriate. And then a lot of people ask about pre-meds. And when I started anaesthesia, we were giving out a lot of pre-meds for anxiety and things like that. What we've realised over the years is that the hangover effects from the pre-meds often lasted longer than the effects of the anaesthesia itself. So if someone's coming in for an inguinal hernia, then we do the operation, we give them all these medicines, but my drugs are now so much cleaner than they used to be in years gone by that they'll get them into your blood system and then get them out again because they wear off. And if you've still got this heavy duty pre-med hanging around, the patient's all grotty and drowsy and vomiting because of that. So we give a lot fewer pre-medications than we used to. Now, every now and again, and you can still have them. You can still have them. It's just much less common. But if people are particularly anxious, then yeah, we can do it. It's not a problem. It can be done. And obviously, there's certain groups of patients that we have to do them. We have to bring people with learning difficulties in, and they don't understand why they're coming for an operation. So we would obviously give them pre-meds and things like that. One of the really important ones is to keep warm. So we know one of the big risks after hernia surgery is wound infection. And we know that if your core body temperature drops, you are at increased risk of getting wound infections. So when you go into the hospital, bring your nice fluffy dressing gown or a top or something like that to keep nice and warm on those cold hospital wards. During surgery, we'd put a warming blanket over you normally to keep your core body temperature up. But it's really good if you can come to theatre with a decent temperature. And then I'm afraid, prepare to wait. So if I've got a list of maybe 4 or 5 patients over the course of the day, I will get there at 8 o'clock in the morning. I will see all 6 patients, and then I will go down to the operating theatre with the surgeon, and we will operate on everybody and just call for patients as we need, as we're finishing the last patient. And we've tried all sorts of things to make it more patient friendly by bringing them in later, just before their surgery, and it all just goes wrong. We end up with an operation finishing quicker than we thought it would, and then you're sat around doing nothing. And to run an operating theatre in the NHS costs £20 per minute for every operating theatre. So in my hospital in York, we've got about 20 operating theatres running 5 or 6 days a week. So that is a lot of taxpayer money going into that. And what we don't want is empty theatres. We want to be working during that time so that we get as many operations done as we can. So I'm afraid what that means is that people that are heading towards the end of the list have to come in at 7:30 in the morning and might sit around for a very long time, and it's quite annoying for them. But again, it's a hopefully not a common occurrence. And my experience, if you tell patients that's what to expect, they're all absolutely fine. If you tell them why, they say, yeah, okay, I get it. It's not great, is it? But I bought a good book, so I'll be okay. And then you'll get called to go down to the operating theatre. And most patients, if they can walk down, they'll walk down. If we need a wheelchair, we can do that sort of thing. Take your dentures and your glasses and your hearing aids with you. Often the rest of your belongings, if you're having an overnight stay, the rest of your belongings will stay on that ward and then go off to your post-operative ward, so where you will go after your surgery, and then your belongings will make their way there. But you need your glasses and your hearing aids and your dentures, because everyone wants to have them when they've woken up again after surgery and recovery, and they want to be able to see and hear. And we also need you to be able to look at the consent form again, because when we check you in, we go through all your details all over again. So all the details that the nurse goes through when you get to hospital, we'll go through the whole lot again in the anaesthetic room before the anaesthetic. And then once you're asleep, we do it all over again when you're asleep. So you get checked in lots of times to make sure we've got the right patient having the right operation on the right side, to reduce the risk. And what you'll find in most theatres, there's lots of people involved. There's a lot of people. And they're all there with their various roles to make things run smoothly. So the actual anaesthetic is all pretty quick. It's a drip in the back of the hand, so a cannula into a drip, and cannula into the vein in the back of the hand. All the monitoring to go on to look at your blood pressure and your heart rate and your oxygen levels, and then off to sleep. And normally that's with an intravenous induction, so an injection into the drip, and then you're out for the count. And those days of sort of counting back from 10 or 20, they're gone as well, because those were much slower acting drugs that you had to be much more careful with. Nowadays, our drugs are much cleaner, much nicer, and people are off to sleep pretty quick, really. So often, once they've got them off to sleep, I'll then turn my anaesthetic gases on and keep you asleep with using these anaesthetic gases that they discovered all those years ago. So after that, we take you into theatre. Most people having a hernia repair will need some part of them shaving. Don't do it yourself. We do it in theatre. There's really good evidence that there's a lower infection risk if we do it with proper sterile blades in the operating theatre. We take great care in positioning a patient for surgery. And that might be that for different types of operation, that will require different things. So if somebody is having a laparoscopic procedure, so a keyhole operation, we might need to strap your chest and your pelvis to the operating table, because the surgeon will often tilt the table quite significantly. We don't want you sliding off. That's a bad day at the office if that happens. So we check the consent form again once you're asleep. We then clean the skin, get the drapes on, and then it's knife to skin, and off he goes. The surgeon gets cracking, and off we go. So what does a general anaesthetic involve? Well, the drip, as I've talked about, an induction agent, some medicine to send you off to sleep. Everyone will get some form of pain-killing drugs, and those are normally very powerful opiates. So the drugs I was using today, for instance, are about 100 times stronger than morphine. So I give a very, very powerful drug, but just a very small dose of it. And that gets us through that severe pain, if you like, that's caused by surgery. It just completely reduces that pain. I then need to put a breathing tube in, and that may be something like an endotracheal tube that you see at the top there, for which goes down through the vocal cords and into the top of the lungs, into the trachea. Or at the bottom, it might be a laryngeal mask airway, and that thing just goes in your mouth and sits on top of your vocal cords and allows me to connect you to a ventilator to make sure there's oxygen and anaesthetic gases going in and out of your lungs. Almost everyone having a hernia repair gets a dose of antibiotics to reduce the risk of infection, and I'll be giving things like anti-sickness drugs and stuff like that. So just briefly, what about other types of anaesthesia? Well, there's spinal anaesthesia that you might hear about, and certainly this works very well for things like an inguinal hernia or a femoral hernia. And we would recommend this if someone's got heart disease or in particularly respiratory problems, so bad bronchitis or emphysema. We might say, look, why don't we not do a general anaesthetic because of the risk of post-operative chest infections and things like that. And we'll do a spinal anaesthetic instead. And that involves popping a little needle in between, right in the middle of your back with a bit of local anaesthetic, and we go into the fluid that bathes the nerves that have come out of the bottom of your spinal cord. So the spinal cord stops really quite high up your back, up at the first lumbar vertebrae. But we actually inject below that and put local anaesthetic around those nerves, and it switches them off. So the pain messages can't come back up from the lower half of your body, but also the motor messages can't go down either. So you can't move your legs, can't feel your legs. It's very strange. You also turn off the nerves to the bladder and bowel. So you can't actually pass urine, can't wet yourself when you've got a spinal on board, and you can't open your bowels when you've got a spinal on board. So that's, if you think about it, that's a voluntary thing to go to the toilet. That's what you have to do it deliberately. So if I turn off those nerves, you can't go. So indeed, some men in particular that have a spinal might need a catheter afterwards because they can't actually pass urine for a few hours afterwards. But it's pretty rare. That's probably 2 or 3%. And an epidural is very similar. It's not quite the same as a spinal. We put a needle into a slightly different space, which is just before where a spinal needle goes. And then we pop a tiny little tube, a bit like the drip that goes into the back of your hand, but it's much longer and thinner. And we put a little tube in, and we can put local anaesthetic down that and connect it to a pump that can run for 2 to 3 days after the operation. If you were having a big operation on you, like a big incisional hernia repair or something like that, or an abdominal wall reconstruction. So those can be very useful as well. And then there's other things we can do which are a bit less relevant for hernia surgery, but things like, instead of sending you to sleep, I can send your arm to sleep. So I could, if you're having a hand operation, I could use an ultrasound that you can see there in the armpit, and using that ultrasound, I can actually see all the nerves that supply the sensation to your hand. And I can put a little needle next to them and inject local anaesthetic and turn them off temporarily. So you have a completely numb hand. So that's the sort of thing we can do. And there are nerves that supply the groin area, the ilioinguinal nerve, and that we can do a nerve block for to provide post-operative pain relief. So then the other things that we think about are what type of surgery the patient's having. Are they having a laparoscopic on the top left there, or robotic on the top right there procedure? And those are both keyhole, and there's benefits to both. Or is the patient having open surgery? And different surgeons, different hospitals will have different facilities and techniques and experiences to offer different types of things. From the patient's perspective, there's a drip in, the monitoring goes on, and they're off to sleep. From my perspective as the anaesthetist, I then have to choose what type of anaesthesia I'm going to use, what type of pain relief I'm going to have to use, depending on what type of procedure we're having. So you've had your operation. Oh, I'm just quickly going to talk about, those robotic or laparoscopic or open. Could be to do with inguinal hernias, for instance. But if someone's having a much bigger abdominal wall reconstruction or a large incisional hernia or something like that, it's a much bigger, longer procedure, and I'm going to need more monitoring. I'm going to need more drips. I might start thinking about an epidural, or as you can see
sorry.
on the left there, wound catheters. And those are catheters that go next to the wound and infuse local anaesthetic to reduce the pain after surgery. Patients having that size of surgery will need a catheter up into the bladder as well, so that we can empty the bladder and see what's going on. Into the recovery room, you'll meet as you're gradually waking up from your anaesthetic, you'll meet the specialist nurses that are trained in looking after airways and looking after post-operative patients. They deal with pain, they deal with nausea and things like that. And we're very aware of nausea. So if you ask a bunch of patients who have had surgery, what would you rather have, pain or nausea? Almost all of them will take pain because nausea is just intractable nausea that you can't get rid of is just horrible. So we will give most of our patients multiple different drugs to try and stop them feeling nauseous. And I'm afraid some people, and I do warn patients about this, some people just react badly and it's really difficult. And I certainly give fairly big doses of drugs to try and stop them feeling nauseous. Pain you can deal with, and most patients expect a bit of pain after an operation. And in fact, what we've learned over the years is that if you give great big doses of morphine to somebody, they're then drowsy, they're more likely to feel sickly after surgery, and they take a long time to come round. And what works really well is that you give a bit of pain relief and then top them up in the recovery room once they're awake, and you top them up to effect. So if they need a bit more, give them a bit more. But it means you're not overdosing them on overdosing, you're not being heavy-handed with morphine type drugs. And then once you're ready, you'll be discharged off to the normal ward or sort of second stage recovery if it's a day case procedure. So what we're looking for in a recovery after surgery, in my mind, the most important thing is good pain control. I often write up pain relieving, so starting with paracetamol, moving up to ibuprofen if you can take it, maybe a bit of codeine if you can take that. If necessary, we could use some tramadol and morphine and things like that. There is a ladder of increasing potency of drugs that we use to provide good pain relief. Paracetamol is a remarkably good drug if you take it regularly, and people don't do that. They just take one or two in the morning and then think, oh, well, I won't. I'll just take it if I need it. And I always advise people to take those 2 tablets 4 times a day, get on top of the pain before it becomes a problem, because that way you move more and you get better quicker after your surgery. What's going on as well is that the recovery process is not just recovering from an anesthetic, it's recovering from surgery. That surgical stress that has been caused by, it's necessary to cause it because you're having an operation, but that causes an inflammatory process to go on in the body. If you imagine if you prick your thumb on a rose thorn, it gets red and inflamed. Well, if a surgeon does a big cut in your tummy and fiddles around and stitches things up, this whole body goes through this inflammatory process. And this is why people feel washed out after surgery, because your body is going through that process that takes several days to get back to normal. It can take several weeks if you're having really major surgery. So I always warn patients to don't expect to be up and about and doing, what you were doing today in the days after your surgery. But what's really important is that we concentrate on ERAS, enhanced recovery after surgery. We don't expect you to be up and about and doing and running marathons and doing the garden, but we want you to be dreaming, drinking, eating, and mobilizing. So get fluids down you, get something to eat, and at least get out of bed and walk around and get to the chair, because that is really important. We've got really good evidence now that leads to better longer term outcomes for patients. Less pain, less complications, all that kind of thing. And we're now measuring it nationally. The hospitals that are graded on how well they're doing by getting their patients doing this after surgery. And I hear, Mrs. Smith is 85. She can't possibly be expected to be up and about and doing things after surgery. And that's rubbish. And probably the older you are, the more important it is that we do it. And the more frail they are, the more important it is that we push gently, that we actually want everybody to be getting going after their operation to improve their recovery. So I was going to touch briefly on, sorry, I've been rabbiting on, haven't I? 45 minutes. Briefly on the complications after anesthesia. This is a difficult topic because splitting complications after anesthesia are very small, and complications after surgery are more common, wound infections and things like that. So teasing them out is difficult, but it's also kind of irrelevant because the patient doesn't care whether it was the anaesthetic or the surgery that's caused the complication. The patient cares about the fact that they've suffered a complication. So whatever it is, we need to do what we can to try and reduce it. But in terms of just the anaesthesia, I'm hoping I'm going to show you that the complications are actually pretty rare. So we divide it. The Royal College of Anaesthetists have got some really good documents on this to sort of allow people to understand complications. So nausea, feeling sick, about 10 to 15 patients out of 100 will feel sickly for up to a day after surgery. So chest infections, between 2 and 20 patients. And these are research projects that have been published. So this is real data that we're seeing that these people at the college have looked through to see, well, what actually does happen after these operations. And so things like bruising or pain from where the drip went in, having a bit of a sore throat because I've had to put that breathing tube down, those things I'm afraid are fairly common. But then when we get to the more serious things, we're talking about rare complications. So the risks of things happening. Sorry, just excuse me. 1 in 10,000. So damage to teeth from the anaesthetist putting the breathing tube down. 5 out of 10,000 people might. Having a cardiac arrest, so your heart stopping, between 1 and 3 patients then get resuscitated from it. Having anaphylaxis to one of the drugs and having a severe allergic reaction. So 1 out of 10,000 people will suffer that. Your chance of dying if you go on a canoeing trip, 1 in 10,000. We don't think of, so there's risks that we face every day that we never even contemplate. So going in a car, your chance of dying in a car is much higher on any car trip that you go in, is much higher than your chance of dying due to anesthesia, no matter who you are. So dying from complications due to the anesthetic, 1 out of 100,000 people. So it's really pretty rare that actually people come to grief. Now, one thing that I've put in there is waking up for a short time, so accidental awareness, and that's one thing that people are often asking about. And that is about 5 in 100,000. But the important thing is the majority of them don't feel much in the way of pain, but they are aware. And it used to be, I remember my mum was aware during one of her operations 50 years ago. And she remembers going and saying to the surgeon and the anaesthetist afterwards, I was aware during that. And they said, oh, don't be stupid, woman. What would you know? In the real proper old-fashioned Lancelot Spratt way. Whereas now we've looked at it, we've examined it, and we know, yes, it does happen, unfortunately. And it's because the anaesthetic vapors have run out or something like that. But it is very, very rare that it happens. And we're very careful to stop it from happening. So again, I try and tell my patients, I don't think that's something that you should get overly concerned with, because you actually underwent more risk coming to the hospital this morning in a car. That was riskier than what you're about to go through. So that was all I was going to do, really. But there's a few questions that came through, I think, weren't there, Jackie?
There were. We had a few questions, and if anybody who's watching this has any questions, then please do use the chat box, and you can ask them of Dr. Yates. So, yeah, what I've got written here as we were talking through, I've heard a lot about hot clinics, where hot clinics for inguinal hernias are becoming a thing with the NHS, where surgeons use local anaesthetics. Will that still have an anaesthetist?
So not often. So it's not something I've got a lot of experience with local anaesthesia. There are centres that do local anaesthesia, mainly sort of smaller inguinal hernias. If you've got bowel going down into the scrotum or something like that, it's pretty challenging to do that under local anaesthetic. I have had a bit of experience, and and it can certainly be done. Most surgeons can do it. I promise you, most don't like doing it. It's you can't get if someone's had a general anaesthetic, they can get in there and they can see what they need to see, and they can get on with it and do it quickly and efficiently without, you need to be able to pull on the skin edges to see what's going on. And if you're trying to do it under local, that can be difficult. A lot of the time, the patients have a lot of sedation for their local anaesthetic. And in my mind, then doing local anaesthetic with some heavy sedation, I would actually rather be there as an anaesthetist and give you a very quick, controlled general anaesthetic, and then have you waking up round in the recovery room afterwards. You don't go home. It doesn't take any longer to go home. You're still home within a few hours after that, if we want to be. So it is being viewed and is being sort of looked at as a way of speeding the process. But I think for some centres that do it and just do it, and there are a few centres around the country, I'm sure it's fantastic and it works really well. But there's not that many places that are doing it as routine. So
We have a few people who have sleep apnea.
yeah.
So they were worried about the anaesthetic. Is there any extra risk to them because of the...
So sleep apnea is not a problem when I know about it. So if somebody's diagnosed with sleep apnea, it's really important to tell the anaesthetist. And what happens with sleep apnea is that when you are asleep, the tissues around the back of the tongue and around the soft palate collapse down on themselves, and you basically stop breathing for a period of time. So apnea is without breathing, without breath. And so and your oxygen levels fall, and when they fall to a certain level when you're asleep, you suddenly wake up again and start breathing, and often patients snore heavily. Now, my job as an anaesthetist is the moment I've anaesthetized you is to take over your airway and to make sure your airway is open. So if someone's snoring when they're anaesthetized, I'm doing a very bad job. So it's not a problem for the actual anesthetic, but it is a problem for waking up afterwards if I've had to give you lots of drugs like morphine, if you're having major surgery. So again, if people are having a day case hernia done, it's not really a massive problem because I'm not giving you lots of really heavy duty, long acting morphine type drugs. But if someone's having the full laparotomy or full abdominal wall reconstruction, it may be that I'd say, look, I think we need to do an epidural for this, because then I'm not having to give you those heavy duty morphine type drugs, and we can have you nice and awake afterwards and minimize the risk from your sleep apnea. So if it's managed, no, it need not be an increase in risk.
Okay. What about people who are asthmatic? Is that
Again, so asthma, if you come in and tell the anaesthetist or the pre-assessment clinic nurse that you're asthmatic, they'll want to know an awful lot about it, about how well controlled your asthma is. And as long as you're not being admitted to hospital regularly or having to have repeated doses of steroids or having regular asthma attacks, again, there's no real reason why it need be a problem. So we will want to know what's going on. If patients do have severe asthma, they can still have an anaesthetic. That's not a problem. Again, I just need to know about it, and I will do things to make sure that I give drugs that aren't likely to cause wheeziness, because some do. I will make sure we've got the right sort of monitoring after the surgery, and if necessary, send someone to the high dependency unit or something like that. There's all sorts of things we can do.
okay? I know this is quite frequent because it happened to me myself. You wake up a couple of days before surgery, and I don't know what it is, but you end up with a cold. You're feeling like you've got a cold and your sore throat, and I hear it quite often in the Facebook group. Oh no, I'm due. Do I have to cancel my operation?
Yeah, and
Is that a problem?
so a lot of people get the dry tickly cough, and I think that's nerves. I think
Yeah.
that's anxiety, the dry tickly cough, but the colds. So what we say is that if it's just a head cold, it's a bunged up nose, a bit snotty, a bit of a tickly cough, I don't mind. We'll deal with that. So, and nowadays as well, patients have been waiting a long time for their operation. We do not want to cancel them just because they've got a bit of a stuffy nose. And there is no evidence that cancelling them for that reason is good for them. Now, if somebody has got a chesty cough and they are coughing up lots of sputum and they've got temperatures and they're feeling shivery and really miserable, don't have elective surgery. That's not a good idea, because that could well be a proper chest infection taking hold that could lead to complications after surgery. So on the whole, a little cough or a cold that's not making you that unwell, it's probably just a virus at the end of the day. There's no reason why we can't go ahead with most operations.
What about age? Is that a factor? Because I know a lot of elderly people are worried that it's going to be safe for them to go through a procedure.
Yeah. So with regards age, it is much less about your your actual age per se, but about your functional status and your how well you are, how healthy you are, what sort of things you can do yourself. So I anaesthetized an 88-year-old lady for a hip replacement, who, if it wasn't for this blooming hip causing pain, she'd be up and dancing. And that's absolutely fine. She sailed through it, not a problem. But, we have 50-year-olds with dreadful heart disease and lung disease and diabetes, that is a problem for me. It doesn't mean you can't have an operation, but the risk profile is very different. So another thing that people worry about with age is the risk of confusion and post-operative decline in their ability to think and do the crossword and things like that. And again, there is a bit of evidence out there that the stress response from surgery and anesthesia can lead to a bit of cognitive problems after surgery. The vast majority gets better with time, but if people are particularly worried about it, I don't routinely mention it because I don't think it's common enough to talk about it. But if people ask me about it specifically, I do say, well, actually, we do need to talk about that when you're making this decision to have an operation. Because if you're living alone and looking after your disabled husband or disabled wife, then any form of decline in your cognitive ability and your clear-headedness might be really, really relevant. So we need to have a think about that. And it might be more family support that we get in, or it might be staying in hospital for a bit longer just to make sure everything's settled down and things like that. So yes, it is there, it is relevant. But on the whole, we wouldn't ever say to somebody, you can't have an operation because of your advanced years. It's more to do with what sort of medical issues they've got going on.
I think then at the other end of the spectrum, I know I found it really difficult when my daughter had to have an anaesthetic. For children, is
Yeah.
the procedure the same?
So the procedures, it is pretty much the same in terms of the actual anaesthetic, but obviously how we deal with kids around it, because they don't understand what's going on.
No.
Kids that can't understand what's happening, um, we need to uh, not terrify them, but at the same time, we need to get on with it and do the operation. So there is no real strong evidence that a single quick anaesthetic for a child has any significant impact. There has been talk for many years about it sort of affecting brain development in the well, this was in animals mainly. This was looking in rabbits and things like that. But we thought, well, it might do in rabbits, and maybe it does in humans. So we've gone looking for it. And certainly in studies where we've looked at twins, where one of them has had an anaesthetic and one hasn't, there's no difference in their sort of academic ability later on in life. But we are careful in saying, well, it's probably not a good idea to give lots of anaesthetics to children, but a lot of the time, for those kids that need them, they need them, and you've just got to do it. And what we do is make sure we've got play therapists who come to theatre with them to distract them whilst I'm doing the nasty things to them and things like that. And we like to get the parents down to the operating theatre as well, and they'll often come in and I'll sit the child on the parent's knee and I'll anaesthetize them sat on mum or dad's knee. And then my assistant who's normally a big burly operating department practitioner with me, will scoop them up and put them on the trolley, and somebody will take mum back to the waiting area and I take over. So we can normally get things done in a fairly relaxed way. And obviously some anaesthetists are better than others and have a better bedside manner and things like that. But the ones that gravitate towards doing more children are really good. Are really good. They're very quick and slick, and it's about minimising the disruption to the child and the unhappiness that you cause. But they're never going to like it, I'm afraid.
No, I mean, you've talked about anxiety, and just to recap for anybody who joined us, since it's about talking, it is a normal thing, isn't it? Everybody's going to go through it.
Absolutely,
Um,
absolutely.
talk to you.
Yeah. This is a once or twice in a lifetime thing that is completely alien from your normal everyday life. So you are going to be anxious. There's no two ways about it. It's very rare I find a patient that says, "Oh, I'm looking forward to this," the anaesthetic. It's just part of. It would be weird if people weren't anxious. And I think accepting that it's normal is probably one of the most powerful things you can do to get yourself through it and say, do you know what? Fine, let's just do it.
Yeah. And what I found, just as we finish off, is that the the staff in the operating theatres and the anaesthetists, they know that and they do everything they can to make it easier for you.
Absolutely, absolutely. I've got
Yeah.
I've got some. I remember training. I had colleagues that would talk for ages to patients, trying to put them at ease. And very quickly, I realised that I'm never going to put this patient at ease. They're lying on my operating table in my anaesthetic room, and I'm about to stick needles in them and do things to them. So they're never going to be at ease. So don't bother spending 30 minutes trying to talk to them. The patient doesn't really actually want that. I don't think they want to be asleep as fast as they can and get on with it and get it done. So I'm afraid that's my take on it. I'll be perfectly nice to them, but I'm not going to have a conversation about the weather and the cricket and things like that. It's come in, be anaesthetised, get you through this, get you home again as fast as we can.
Okay. So a question's just come in as how much does weight affect things?
So weight, being a little overweight
Yeah.
can be a problem. There's no doubt about that. Everything is harder for the anaesthetist. It's harder to get drips in. It's harder to ventilate the lungs. It's harder to get a breathing tube in. Okay, there's no doubt about that. But the fact is, we do it, and we do it a lot because we see a lot of overweight people. And once the patient's asleep, then things tend to be fairly straightforward from the anaesthetic point of view. There's certain things we need to be careful of. They're more like people who are bigger are more likely to get injuries from maybe pressure areas on the table and things like that. So we do see problems with that. It can be a problem for the surgeons in terms of access. And just doing a hernia repair on someone who's a lot bigger can be technically just more challenging. But also, unfortunately, what we know is that the chance of recurrence of the hernia coming back is much higher if the patients are too overweight. And so I know surgeons I work with will give patients a target weight to the amount they want you to lose so that we can reduce the chances of it coming back. And that target is not to do with making the anesthesia safer or making the operation safer. It's about in getting the outcome that the patients want at the end of all of this.
Yeah. You don't
Achieving
want to
that
have to go
outcome.
through it again.
Exactly, exactly. We don't want to do it more than once.
No. Okay. So I think I can't believe how long we've been chatting.
I know.
I've learned so much about it tonight and so many things. Oh, yes, Deborah's saying absolutely fascinating to learn about the history and the training and everything you've gone through. It's so reassuring.
Good. Well, thank you very much. So I just put up at the end there some patient leaflets. So the Royal College of Anaesthetists has a lot of patient leaflets about all these types of things. And some of them are really good. And a lot of work goes into them to make them, accessible so that people can actually look at them and use them. And we certainly hand them out in my hospital to patients coming in
I did share that
yeah,
link that you sent me, and I think it is worth. I think we'll put it in our file that people can then go and refer back to because it was very interesting. So thank you ever so much, Dr. Yates, for tonight. It's been a real pleasure talking to you.
very welcome.
Been
Thank you for
really
having me along.
interesting.
Yeah,
So thank you very much from Deborah again.
yeah. And obviously,
Yeah,
and Jackie, if people have questions that they don't want to ask now, then obviously they can come via you, and I'm happy to answer things. So
thank you.
not a problem at all.
Thank you. And hopefully in the near future, we'll arrange one on prehab as
Yeah,
well.
yeah, great stuff.
That's
Okay,
good. All right. Thank you very much. So David said thank you. Very informative.
very
Thank
welcome.
you.
Thank you.